Neurological assessment on neurological problems, part 3. Okay, a ventriculostomy, sometimes lovingly called a brain drain by the people who work in neuro ICU, is a tube that is inserted into the ventricles of the brain for ICP monitoring or to drain extracerebrospinal fluid. It's usually left in 3 to 5 days. And this is what it looks like. This is an artist's depiction of an intraparenchymal ICP catheter and ventriculostomy ICP catheter. The middle, that's what's on the left. The middle shows that it's placed through a bolt system, and then on the right it shows how it's tunneled, so it stays there. Diffuse axonal injury, shaken baby. Never shake a baby. This is usually due to a missile injury, but it can be due to shaking. Mild, you'll have coma for 24 hours with some posturing, and then they'll get better. Severe, the coma is longer than 24 hours, and it has a very poor prognosis and will have some residual if they do wake up from it. Guillain-Barré is possibly an IgG-mediated or autoimmune problem, a cell-mediated immunity problem that results in demyelination of your peripheral nerve. So it starts in the extremities, and an infection can be a cause. Paralysis will start at your toes and progress over hours to days and can go all the way up and involve everything so that you can't even blink and you cannot breathe and you have to be on a ventilator. In your cerebral spinal fluid, you'll have a high protein count, that normal cell count. The average time frame that this occurs is 1 to 3 weeks, and it usually plateaus for 2 to 4 weeks before it starts to get better. A nerve conduction study will show a delay in nerve conduction. Treatment is plasmapheresis, which costs about $4,000 a treatment. Plasmapheresis removes the antibodies and the immune complexes and the protein-bound toxins. It adds albumin, electrolytes to your packed red blood cells, and then returns those to the patient. It removes about 200 to 250 milliliters of plasma per kilogram in 4 to 6 treatments over 10 to 15 days. And they usually do the treatments every other day. As far as the nurse is concerned, all we have to do is provide support, because this is done by the Red Cross. We can also administer IV IgG, since it seems to be a loss of that. That's a part of the problem. And we can administer IV steroids. And this is showing Guillain-Barré syndrome. Took care of a gentleman who progressed to the point where he could not even blink. The only way we knew he could hear us is we had him on an EEG monitor, and when we talked to him, his brain waves changed. As you get better, it progresses backwards. So it starts then at the head and goes back down to the feet. If you've been in coma for a long time, it does cause some permanent deficit where you may need to use a cane or a walker, but usually there is no permanent injury, but they do require physical therapy. And Guillain-Barré, for some reason, seems to occur more in this area because it is a very rare condition. But an unofficial survey by me of peers at every hospital here, we tend to have 2 to 4 patients every winter at every single facility. So that's rather a fairly high amount for this area. Maybe because we get more respiratory infections. I don't know. Myasthenia gravis is a progressive neuromuscular deficit due to a decrease in your acetylcholine. Symptoms are muscle weakness, ocular weakness, ptosis and diplopia, facial drooping, dysphagia, and trouble holding their head up. And it will progress to respiratory arrest. The way in which you assess this is you administer Tensilon, which is a drug that you will give IV, and you will not tell the patient what it is or what you expect to get from it. You can tell them it's Tensilon, but you don't want to tell them that you expect the symptoms to go away. But that is what you expect. You expect once you administer it that they should feel better, because this is a form of acetylcholine that you will be administering, and so they should get better. A myasthenia crisis, or a cholinergic crisis, causes salivation, lacrimation, urination, and defecation. That's when you have too much of it. They don't have enough. And so myasthenia gravis starts at the head, works its way down. Multiple sclerosis, on the average, starts at the feet and works its way up. This again is from the memory book showing it. This is also an autoimmune problem, tends to have remissions and exacerbations. Onset's about 20s to 40s. They end up in a wheelchair and have some major problems. Annette Funicello, if you know who she is from Mickey Mouse fame and the Beach Party movies, has multiple sclerosis. Madeline Rue did too. She was an actress for television. Parkinson's disease is due to a decrease in your dopamine levels and an increase in your acetylcholine levels, because dopamine and acetylcholine tend to be antagonists to the others. Dopamine relaxes, acetylcholine agitates, so that when you don't have enough dopamine, you end up with tremors. Pill rolling tremor is characteristic. It's like you're rolling a pill between your hand, and then you go to reach for something, and that tremor stops. You can have rigidity of your muscles, akinesia, trouble walking, restless, slow speech, difficulty swallowing. Treatment is levodopa, which is a metabolic precursor for dopamine. Oftentimes it's given with carbidopa because that prevents the peripheral breakdown of levodopa, so you don't need to give as high a dose of levodopa. Sometimes they'll give Sinemet, which is an antiviral, but it also helps with the tremors. Parkinsonian crisis is a sudden, severe increase in rigidity and tremors that can lead to respiratory arrest and dysrhythmias. Usually onsets this disease after the age of 50. Michael J. Fox started at 21. He's atypical, but he's also had all the treatments to help and is doing amazingly well. But these patients who take levodopa need to be on a low protein, low B6, and no alcohol diet. Because all three of those things will interfere with levodopa and decrease the amount of dopamine that's available. And they end up getting this lovely mask-like appearance, this blank expression. That's late. Parkinson's is very rare in the black population. This is from the memory book. And cogentin is one of the drugs that might be given to control Parkinson's because it's an anticholinergic, so it blocks acetylcholine, so that will help decrease some of the shaking and the tremors that go there. So goals of care for people who have neurological disorders are to maintain adequate cerebral tissue perfusion, keep the ICP less than 15, prevent complications, restore neurological function, and maintain their safety. The therapeutic management of increased intracranial pressure is temperature control. You want that temperature to stay between 33.5 and 34.5 degrees centigrade, because if not, they can develop dysrhythmias. Blood pressure control is a must, but you want to keep it in the high normal range because that way you maintain circulation to the brain. You treat them with sedation. And you use care because you don't want to vasodilate too far. Seizure control is essential. You'll administer Dilantin and or phenobarb for seizure control. You can give mannitol because that will increase perfusion to the ischemic areas, causing cerebral vasoconstriction, and it decreases intracranial pressure. That's one of the osmotic diuretics that you will use because mannitol is a simple sugar. And your goal is to prevent that herniation, so you're going to pull fluid off. You have to check their CVP. You want to make sure your patient's not dehydrated elsewhere. So you look at that also. Oftentimes you will administer a loop diuretic on alternate hours to help get rid of that fluid. But fluids must be managed very carefully because dehydration would decrease cerebral perfusion, and then that would cause further problems. Oftentimes lidocaine will be administered before suctioning because you don't want your patient coughing. That increases intracranial pressure. You want to decrease their metabolic demand by administering barbiturates because they decrease free oxygen radicals, lower blood pressure, and shunt blood to areas of decreased flow or damage. They decrease the oxygen demand on the brain. But the thing about barbiturates is they have to be tapered off. You cannot abruptly stop them. And they can cause hypotension, hypothermia, and myocardial depression. Now, as far as nursing care for someone with an increased intracranial pressure, positioning is important. Elevate that head of the bed 15 to 30 degrees. Keep the head in a neutral position so that there's no problem decreasing drainage from the brain. And make sure there's no hip flexion so that cerebrospinal fluid can drain out to where it's supposed to. Again, administer fluids. Make sure they don't become dehydrated. Control any nausea and vomiting. Give them some nutrition as early as you possibly can. Tube feedings, if they're able to take it themselves, are preferable to TPN. Control their fever. Fever is always a bad sign, so you want to control that. Prevent constipation. You don't want them straining. Prevent infection. And prevent any corneal abrasions. Make sure you check your urine-specific gravity. That will help you identify if your patient is getting getting sufficient fluids. You want that specific gravity to be between 1.01 and 1.02. It's really important. If it's higher than 1.02, your patient's getting dehydrated. If it's less than 1.01, they're getting overhydrated. And this is looking at the nursing care, diagnostic treatment, complications, interventions for someone who has increased intracranial pressure. And this is from the memory book to try and help you remember some of those changes. Sometimes the patient will require a craniotomy, oftentimes if they have cancer. Preoperatively, you'll have to do a CBC, BUN, creatinine, blood sugar, chest x-ray, electrocardiogram, and type and screen. And you're going to assess them following it for diabetes insipidus, which is due to a decrease in your ADH. This is usually self-limiting. Or SIADH, due to an increase in your ADH secretion, where the body saves water and dumps sodium. This is also usually self-limiting. You're looking for a cerebrospinal fluid leak, and this you would notice halos forming on the sheets from the ears or the nose. And if you test it, the glucose will be 30 milligrams per deciliter or greater. Treatment is to elevate the head of the bed and keep them on bed rest. A DVT, stress ulcers, and pneumonia are all possible complications of a craniotomy. For spinal cord injury, methylprednisolone IV for 24 to 48 hours to decrease the edema that occurs there. Surgery, a laminectomy, a fusion or rods. Now, prior to surgery, or sometimes afterwards, you'll have them in skeletal traction. That stabilizes the fracture. They may use Crutchfield tongs or Gardner-Wells skull tongs or a halo ring or halo vest. Now, this is attached to weights to a rope suspended from the tongs to provide traction. A halo ring is attached with 4 pins, which the patient wears for 8 to 12 weeks. A halo vest has fleece and comes with extra fleece to pad your bony prominences. Now, the thing with the pins that are in the head, you have to cleanse them initially with betadine, but then with soap and water. If they become infected, they must be removed and then replaced. If you hear a clicking sound or shifting pins, that indicates the pins are loose and you have to tighten them before they fall off. Because if they fall off, you got to put them back. And that's another surgery. A laminectomy is where they go in and they remove part of the laminar process that's probably impinging on the spinal cord. Fusion, they usually do 2 to 6 vertebrae. Rods are put in with screws and glue to the posterior spine. Some of the special beds that they might use might be a striker frame, which is the oldest form. This will have side-to-side lateral turn and will put the patient prone or supine. We also have the rotorest bed that's available that does a similar thing. It's a little more expensive, but it's much newer and has a few more ports that you can get into. These have strategic sites where you could put in for a bedpan or a urinal or help to do pericare or whatever. Nursing care by systems. For the cardiovascular system, the alteration will occur if the damage is above T6, and hypotension is a risk. Alteration in thermal regulation system is what causes the hypothermia, and then that will lead to bradycardia with sinus arrest, and that requires a temporary pacemaker. Orthostatic hypotension is also a risk, so you may want to put on an abdominal binder or use anti-M hose or EPC cuffs to help with that. They also risk for deep vein thrombosis, so you'll have them probably on low molecular weight heparin. Pulmonary is the most common cause of mortality with a spinal cord injury. If they have the problem between C1 and C2, they require a ventilator. If C3, they need a ventilator at bedtime. And you never give succinylcholine after 72 hours after the injury, because that will increase the amount of potassium that's intravascular and can lead to a cardiac arrest. So it's important to assess your respiratory status and your blood gases. A pneumo belt assists with expiration. They require frequent suctioning, and you have to hyperventilate with 100% of O2 to prevent that bradycardia risk. Chest physiotherapy may help, but remember, you don't do it just before a meal or just after a meal. After you get up and before bedtime are two of the best times. Musculoskeletal contractures are a risk. You need to do range of motion. Sometimes you need to use high-top tennis shoes. Remember to take them off periodically because you don't want any skin breakdown. And skin breakdown is also a risk. So you want to make sure you turn your patient and look at them. And make sure they're on a diet that's high in fiber, because elimination is a problem. They're going to need bladder and bowel training so that they can become a little bit more independent that way. You want to use warm fluids to stimulate the gastrocolic reflex and increase peristalsis and contractions in the GI tract. So give them some warm water about 20 minutes before they want to have a bowel movement. That will help, as well as the foods high in fiber. And you want to initiate a consistent time for defecation. Initially, you're going to use a glycerin suppository followed by rectal stimulation. Eventually, you're only going to need rectal stimulation to initiate that bowel movement. This is from the memory book. It's talking about anti-epileptic drugs that you might use to care for somebody, things you need to look for, and I just thought you might like that. And I